Hello, everybody, and welcome to your lunchtime webinar with the Alberta Association of Optometrists. Thank you for joining us. Today, I'm pleased to present Dr. Alia Cappellani, who will be presenting on Shaping Futures, Pediatric Eye Care for Health Professionals, Guiding Healthy Vision from Infancy to Adolescence. Dr. Alia Cappellani received her Doctor of Optometry from the University of Waterloo and completed a cornea and contact lens residency at NSU Oklahoma College of Optometry. She is a fellow of the American Academy of Optometry and the Scleral Lens Society and serves on the Alberta Association of Optometrists Council. Dr. Cappellani currently practices and assists in resident supervision at Mission Eye Care Center for Dry Eye and Corneal Disease in Calgary, Alberta. And without further ado, I'm going to hand it over to Dr. Cappellani.
Hi, everyone. Thanks for joining on your lunch hour. I know I've heard some people are taking time off, so we are recording this for people to watch back later. And so today we're going to kind of go through a few things. We're going to go through eye examination recommendations for children. So kind of when to get those done for healthy kind of age norm, and then when to come in for emergencies. We'll also go through like the goals of a child's eye exam. So kind of what we're looking for when children are having their eyes examined, what is normal versus what is not normal for how the eyes develop. We'll look at common pediatric eye disorders, anything from glasses prescription to eye turns to ocular diseases of the eye. We'll go through exam skills. So lots of times I get questions, how do you ask a child to read an eye chart? How do you see how they're seeing? How do you, get them to look in that slit lamp in the microscope? And the answer is like, we actually usually don't until they're at that age norm. We have all these tricks and tips and ways that we actually examine a child's eyes and see how they're seeing without them actually having to tell us. So we'll go through those and show examples, and then as well as the coverage that Alberta Health provides towards a child's eye exam. And so guidelines for an eye exam, this actually came up with a combination of Canadian optometrists as well as ophthalmologists, in addition to pediatricians and family doctors. And so this kind of working group of people looked at when is the best time to get an eye exam. And so from their report, this kind of lengthy report, they determined that having an eye exam is at least a vision screening before the age of 3 years old is very important. And this is kind of to rule out any sort of large eye conditions that's going to be detrimental for their vision health going long term. Amblyopia, something we're going to hit on later. As well as a full comprehensive eye exam before the age of 5. And the reason for that being that's before they get into grade 1 and where they're using their eyes to learn. And so this kind of joint effort from these experts in all these fields here, that's kind of what they came up with. I'm going to kind of further talk to what our association, so the Canadian Association of Optometry, recommends an eye exam. Kind of at the bottom here, I'll go towards that in a second. I'll zoom in on this bottom portion over here. But our Canadian Association kind of differentiates a vision screening versus a comprehensive eye exam. And so a screening, a sight test is just a quick screening. Sometimes that can be done at schools. Sometimes it can be done in a family doctor or pediatrician's office. And basically they're just like looking, is it abnormal? Is it normal type thing for kind of visual acuity and eye disease just grossly overall. Versus a comprehensive eye exam. It has these kind of 8 pillars here. A little bit more detailed into the history, the vision measurement, color vision measurement, eye movement measurement, eye health measurement, and then kind of even into the brain, and as well as if there's glasses needed. And so zooming in on this bottom portion here, how often should we have an eye exam from both the Alberta Association of Optometrists and the Canadian Association of Optometrists recommend a child eye exam 1 time between the age of 6 to 9 months is the first one, actually. The second one being anywhere between the ages of 2 to 5, and then annually when they're kind of in school, so ages 6 to 18. And we'll see that in a second why we recommend that. And then just of note, kind of healthy adults every 2 years, and then over 65 kind of annually. But of course, we're not focusing on those two. We're just focusing on the children for today. So what are we looking at these kind of three key eye exam points? And so the first one, again, 6 to 9 months is recommended, kind of a quote unquote baseline. What we're doing is just kind of gross overall. Are the eyes developing appropriately? Number one. Number two, are the eyes aligned? Are they moving together? Are they focusing? Are they fixating, following, tracking? Is there any sort of high refractive error? So outside age norms. So when babies are first born, their eyes can be actually large refractive errors. That's not abnormal. But as they grow, they should kind of go towards kind of no prescription around the age of 7 to 9-ish. So something where we see these abnormal prescriptions and we just kind of watch it. But if it is outside the age norm, we are going to recommend glasses, which will be pertinent for their eyes to grow. Other things we're looking for: excessive tearing, crusty, are the eyes healthy or not type thing. That first word there, leukocoria, we're going to dive into that a little further later on. But that's basically the pupil reflexes. Are the pupil reflexes the light shining into the pupil, the light coming back, is that equal between the two eyes or not equal? And that can actually give us signs of some eye pathology. The second visit, anywhere again, usually ages 2 to 3, somewhere in there. Again, we're checking the same things. Are the eyes healthy or not? Is there a large refractive error? We can actually assess color vision at that time. And are the eyes working together, teaming together? At 5 years old is kind of the third visit. Usually I say like before kindergarten, or sorry, before grade 1 or in kindergarten, even in grade 1, that's not too late. And we're checking for, again, the same thing: refractive error, binocular vision, eye vision, movement, and then the health of them, and then annually. And so why do we recommend annually for kids while they're in school? And it's because of this stat here: about 25% of school-age children have vision problems. And so um, children, they think that their vision is normal. They don't know what good vision is versus what not good vision is. And so that's our job as optometrists, is to find those children, find that 25% of children that don't have, a vision, adequate a vision for them to be learning in school. And again, you'll see how we can do that. But that's a staggering number. 1 in 4 kids at school can have a vision problem. And of course, this is going to just cause them to delay in school. And so this is the importance of the eye exam, so that we can assess these, find these, and help them, so that we can help them learn and thrive kind of with their peers, and they won't fall behind. The National Institute of Health kind of finds that the uncorrected refractive errors, such as myopia, hyperopia, and astigmatism, are the most common causes of vision impairment in children. And so those are things that we simply correct with glasses. And so that's the most common cause of vision impairment in children. We can fix that with glasses. It's a fixable thing. So it's more our struggle is finding them, and from there, it's easy. We can correct it. And then the study kind of does go on to identify strabismus in about 2% and amblyopia in about 5% of children. Again, we'll discuss those kind of later on, but just seeing kind of the impact of eye diseases on children. And so the key to that is early intervention, kids and early detect, earlier. So move to normal development. So what is normal for the eye? And so we're actually, eyes are stimulation to see. And so that's when the development is kind of going very fast. But when we're first born, we have really minimal vision. You can see at the top corner there. It's kind of only in black, white, grays color, no detail. We can kind of sort of see hand movements and smiley faces early on, more towards the 6 months or so. At about 1 year old, that's when we see about halfway down that vision chart, kind of the 20/40. We're starting to see a little more things. We're also starting to walk at that time, so that all kind of makes sense. And it's about 3 to 4 years old when we can reach almost that 20/20 vision at that time. So, it's something that vision is not developed when we're born. It just fastly progresses after as we're born and kind of get out into the real world. So that is normal. Things to look out for that is not normal, so abnormal, is any sort of frequent blinking, eye rubbing, squinting, head tilts, excessive discharge, and crusting. A little bit of that can be normal, but lots of that is not really. Redness of the eyes, inability to pay attention. So there's some times where children are actually, thought to maybe have some sort of learning disorder or like ADHD or whatnot, but it's actually that they need glasses. That's really what they are. They can't see, so they can't focus. And then any sort of avoiding of distance work, so holding the reading material kind of up really, really up close, bringing things close to their face, or avoidance of near work. So if they're just, not wanting to read, not wanting to color, things like that, those are signs to look out for that vision might not be developing normally, and to come in and see an optometrist. So moving on to common pediatric eye disorders, again, what we said, the most common being refractive error. So that being hyperopia, farsightedness, myopia, nearsightedness, or astigmatism, which is more so to do with the shape of the eye. One orientation of the eye is a different prescription, up and down, then side to side. And so the glasses to correct astigmatism would have to just mimic that. And so there's all these different guidelines for what to prescribe when, what is normal, what is not normal. I didn't want to add all those numbers to overwhelm you in this presentation, but kind of just more grossly, anything over 4 diopters of a prescription at 1 year old, you have a risk of decreased vision development in the eyes. You even have a risk of an eye turning inwards. And so they associate that with kind of poor visual perception skills and some learning disabilities. And so that's something where at that time we would prescribe a prescription of that for farsightedness. For astigmatism, anything over a 1.5 of prescription or around 3 to 4 years old is associated with poor recognition acuity. Astigmatism kind of causes the letters to kind of merge into each other, kind of like street lights out on the street, those kind of starburst glare halos. So just imagine what it's doing to that, like fine print on a book or whatnot. They're kind of blurring into each other. And so that's why it can be kind of poor recognition if we have higher amounts of astigmatism. The astigmatism we have at about 3 to 4 years of age is actually what we usually have at adult times. Myopia is something we'll just talk about quickly way later on in the presentation, but we're seeing that increase at all ages. And so associated with more near work that we're doing and the less outdoor time that we're doing, we're seeing more nearsightedness. So something, of course, to have on our radar, and we'll talk about that more later. Other common pediatric eye disorders, so strabismus, that's an eye turn or cross-eyed. Those two terms here, we'll talk about the next one on the next slide, strabismus and amblyopia. Lots of times they are grouped into this kind of quote unquote lazy eye. And so I always make sure I want parents to know the difference between strabismus and amblyopia. Strabismus being where the eye is turned or crossed. Happens in about 4% of children. And so the eyes can be crossed inwards, outwards, upwards, downwards. Basically, just the eyes are not aligned with each other. The most common for children is to have the eye turned inwards. And then next up is the kind of outwards. Less commonly is the up and down, but it does happen. And then another way that the eyes can turn is actually what's called accommodative. So when we focus on something up close, as we focus, our eyes come in. But with that inward movement of the eyes and kind of how our eye muscles change and focus, one eye can actually turn inwards just for the up close. When we look far away, the eye would kind of go back normally aligned. And so these are corrected usually by glasses for kind of step number one. And then sometimes prism needs to be added to the glasses. And then if those don't help, then for children, we do strabismus surgery. So correcting the eye muscle, correcting the eye turn. And then if this is left untreated, what happens is that the eye that is turned in the wrong direction, the brain starts to ignore it because if the eye that is turned inwards, if the brain uses the vision in both of the eyes, it's actually going to see two because it sees the normal one, the straight ahead one, and I'll see a second image from the turned eye. And so that's how we get double vision. But since the brain is very smart, it can actually kind of blur out that one eye and kind of start to ignore it. And so it'll ignore it. And then what happens is that brain pathway doesn't develop. And so if the brain pathway doesn't develop, then the visual cortex doesn't develop. And so that's called, the term for that is suppression of the eye. And then that leads to amblyopia, which is what is another common pediatric disorder, less common, so kind of that 1%. And this is kind of, again, layman's terms, the true kind of lazy eye. And so amblyopia is when there is a reduced best corrected vision in one of the eyes, sometimes both. It's rare, but sometimes it does happen in both eyes. And so one eye has lower vision, so less than kind of 20/20. And that, again, is amblyopia when, say, when they're older or whatnot, there's no structure or pathologic abnormalities. And so something that if it's not caught when we're younger, or older, we have one eye that's 20/20. Despite a glasses prescription, the other eye is only best corrected to 20, let's say 50 or something like that. It's not seeing as well as the other, and you have to first rule out any sort of disease. So any disease from the front of the eye to the back of the eye, even with best corrected vision, that eye is not going to see great. And that is because, again, like I was saying, those brain pathways didn't develop properly. So there will be nothing really to help that eye see. Now, the good news is when this is caught early, when we're young, and this is caught kind of before the brain has locked in its development, we can treat that. We can help those brain pathways develop, and kids' brains are amazing. Kind of the prime period to prevent amblyopia, they say, maximum ages 7 to 9. But we do see some brain kind of adjustments and changes and development beyond that. But kind of the studies show around ages anything lower than 7 to 9, we have a pretty good chance to recover those vision pathways there. Amblyopia can result from just abnormal development. So whether that be refractive error that just goes uncorrected, again, beyond those kind of prime ages, age 7 to 9 and below. A strabismus, so an eye turn like we just discussed. Or vision deprivation. So anything that causes the eye not to see at all, it kind of blocks the vision from that eye. So whether that be ptosis, which is a drooping eyelid, or congenital cataracts. Those are kind of the common ones. So if we're born with cataracts, that one eye is unable to see, so then that one eye is unable to develop, therefore the brain pathways as well unable to develop. Other things, less common, if we wear our bangs over our one eye, that was maybe one, then we are not seeing out of that eye again. Not so common, but that's something else that I've seen them in the past. So of course, something that can be preventable when detected from an early age. Moving on to kind of pediatric ocular diseases. So some diseases of the eye that we see. So a pretty common one. Lots of times this is what brings the children to either the doctor or the optometrist, of course. And so that is conjunctivitis or pink eye. It's basically inflammation of that front surface of the eye, the conjunctiva. Signs of it is redness, tearing, discharge, mucousy discharge, white, yellow, itching of the eyes. They can be painful sometimes too. Many different causes of conjunctivitis, anything from bacteria, viral, or allergic. And so we are trained, obviously, to see the signs and symptoms of those and determine the cause, and then we treat it. Bacteria, of course, we need antibiotics for that. Viral, lots of times that's more just self-limiting. If we have a cold, we can get a pink eye, and there's no real treatment for colds or flus other than just kind of get through the virus. But symptomatically, we can treat that with kind of tears and cold compresses. And then as well, allergic. So lots of times in the spring or in the fall, and being here in Calgary, of course, or even Alberta, it's kind of funny. Allergy season can be at any time. That's usually kind of happens in both eyes. You have the itchiness, you have that nasal involvement, so kind of sneezing and whatnot associated with it. That's probably the most common one I see day to day in kids. Less common so, but all important. Ocular disease of congenital cataracts, and so this is when a lens opacity, so the lens in the eye becomes opacified, and that's just from birth. We have natural cataracts, which happens in older ages. And then we have congenital cataracts, which happen when we're first born. Basically, the pupil reflex when we're looking in the eye is cloudy. Looking at this photo here, we can see this right eye here is normal, and then the left eye is kind of that white reflex, and that's actually what we were referring to earlier as leukocoria. That'll come up later again, but we can see that the lens here is hazy versus this lens is clear. The light's getting all the way to the back of the eye here versus the lens is being stopped and impeded over on that left side there. And so what is done in these cases is, of course, to recreate that smooth pathway in the eye. The cataracts are actually removed when we're young. And then we need some sort of optical correction. Now, the lens in the eye provides about plus 30 diopters of prescription. So that's a pretty high prescription, plus 30. And so you can imagine glasses are pretty thick if it's a plus 30. And so lots of times their correction needs to be in a contact lens. And we fit little kids with contact lenses in these cases so that they can see, they have the chance to develop. And then eventually, when they're a little bit older, it's safer to do cataract surgery at that time. And so they'll get in a new kind of artificial lens implant when they're just a little bit older, and it's safe to do so. Next up, this one is probably the most important one because it is vision and life-threatening. It's called retinoblastoma, and so it's a malignant intraocular tumor right from childhood. It is very rare, so 1 in 15,000 births, and that accounts to maybe around 50 children a year in Canada. So very, very rare condition, but again, life-threatening, vision-threatening. So it is an urgent condition. About 10% of these children have a family history, but lots of times it kind of just spontaneously comes about. And then again, we can see that same theme, the leukocoria, that white reflex in the pupil over again. It seems to be the left eyes in all these situations, but this little boy, the left eye, that white reflex back, that's not normal to have, and that it could be a sign of retinoblastoma. And then below, we can actually see that intraocular tumor in the eye there. And so again, it is quite rare, but it is the most common intraocular pediatric tumor, and then it accounts for all children's cancers. It's about 3%, makes up 3% of all childhood cancers. And so again, like we said, it's urgent referral to an ophthalmologist, depending on what stage the tumor is in. They either use kind of freezing therapy, chemotherapy, or enucleating, so removing the eye, again, depending on the stage that it's at. And unfortunately, next one we have to talk about the non-accidental trauma or child abuse. We can actually see that in the eyes. You typically see lots of hemorrhages, intraocular hemorrhages, preretinal hemorrhages, different stages of bleeds in the eye. And so this does require an urgent referral to the pediatric ophthalmology or the pediatrician team, and then as well as mandatory reporting of this. This photo over on the side there, unfortunately, was a 4-month-old that showed up to the emergency room. The top two images there, the right eye and the left eye, various hemorrhages also associated with intracranial hemorrhages, rib fractures as well. But you can see the eyes, they can heal themselves quite well. The bottom photo is about 6 weeks after that. So the blood has kind of all drained and gone away. But of course, very, very sad cases, but something that we can see through looking at a child's eyes. Retinopathy of prematurity. So this is when abnormal blood grows in the retinal vasculature, and typically happens in premature infants. These when we're born, of course, our eyes are not fully developed, and so they're developing rapidly after we are born. And when that happens, if there's some sort of lack of oxygen at any point, so the most common risk factors being if we're born at a low weight, so that's less than 1,500 grams. If we're born prematurely, so less than 30 weeks, or if we're actually given supplemental oxygen. Those are the risk factors. And so the reason being is the eyes, the blood vessels, they're growing and something happens, something abnormal. So they have a lack of oxygen. And when they have a lack of oxygen, they grow quite fast and rapidly and abnormally. And so anything that's like built fast, if we can think about anything built on a fast timeline, it's not going to be built well. And so that's what these blood vessels are. They're not very well built blood vessels. So the walls of them are leaky. The eye can actually, they can grow into the jelly fluid of the eye, and that causes kind of traction a little bit. These leaky blood vessels can be pulled on, and then they break, and the blood leaks, and they can be pulled on and pull the retina along with it, and that would lead to retinal detachment. And so the treatment for these ones are kind of laser. The laser kind of stops that blood vessel growth there, or the what's called anti-VEGF treatment, anti-vascular endothelial growth factor, basically an injection that stops the leakage of these blood vessels and stops them from growing. And so child eye exam skills. So what are we doing during the child eye exams? Kind of how are the child eyes tested? But of course, we don't call them tests for children. That sounds scary. We never want that. We always want the eye doctor to be a fun place for kids, something that they enjoy to come to. Doctors' offices are scary, and we understand that. So I like to personally call the eye exam like tests that we do for kids games. We're just going to play some games, check the eyes, making sure they're working well, playing some fun eye games. And so, that opens them up a little bit, and gets them excited for their eye exam most times. They can be shy, but of course, slowly every time we come in, we play some more games, some different games, and usually they start to kind of begin to remember and engage with us. So we kind of go through these series of tests here. I'll go through them. So case history. Anything from the beginning for little young children, again at the 6 to 9 months is kind of when we gather this, but anything kind of prenatal that might affect the child, so infections during pregnancy, drug use during pregnancies, things we want to know. Were they born full term? Were they premature? What was their weight when they were born? Were they given any supplemental oxygen? Any sort of delivery complications we'd like to know. And then are they meeting the developmental milestones? And parents are really good at knowing these things from their doctor's visits. Other important things to know are the medical history. So, are they on any medications? Are they on, do they have any allergies to medications or non-medications? And then hospitalization. So sometimes parents they have a lot going on. Absolutely, that's they say, oh no, my child's healthy, and they're like, oh, they were hospitalized for this or whatnot, and so that brings it out sometimes if kind of we say something like hospitalizations, and that brings out some sort of pertinent medical history for us. Other important things to know, family history. So if there was any sort of glasses wear in the family or refractive error in the family, always important to know because those can have some sort of genetic passing down. Any sort of eye turns as well. That is in the genes somewhere. Lots of eye turns. It's even like people like, oh yeah, their aunt has a eye turn or something like that. So that is commonly in the family history, as well as ocular diseases. So commonly, cataracts is probably the most common one of ocular diseases in the family, but macular degeneration, glaucoma, anything we want to know about the eyes. And so we'll always ask these questions. And then vision acuity, again, like I was saying, how would you test a child's eyes, reading the eye chart? They absolutely can't do that. And we don't make them. So there's different ways to determine the infant's visual acuity, more so objectively at first. And then, as they grow older, we can do more subjective, subjective being the best. But when they're young, we have to go with the objective. And so is better than not getting it at all. The what's called the optokinetic nystagmus, the OK drum, is that top image there. And so basically, you spin that kind of wheel type thing, and the child's eyes should follow that movement of the eyes. And if it's abnormal of any sort, that could be a sign of this inability for the eyes to see appropriately. There's also an app for that now, so you can even get that on your phone, so we don't have to go buy that piece of equipment. Fixating and following is a good one for little kids. So they just need to see if they can watch you, whether that be one eyes or both eyes together. That second picture there, there's a little kind of toy, something fun for them to look at. They fixate and follow that with their eyes, and lots of times they do reach out for it. So those are again all good signs that the eyes are developing at that age. It's good. They're working singularly and together. And then something called preferential looking. So that bottom photo there, you have paddles of different gradients, and you compare that to a paddle with no gradient. That photo is not there, but we always want to look at patterns. Patterns is something you want to look at, and so the smaller the pattern we can detect versus the paddle that doesn't have any patterns, that can tell us how a baby is seeing. And so those are, again, some fun things, kind of objective, mixture of subjective in there for when they're young, but we can still determine if their eyes are seeing adequately. Moving on into, as we get a little older, we can do some symbols, usually around 3 to 4 years old. We can do those symbols there. And then as we know, our numbers more so going into kind of kindergarten, grade 1 and above. The numbers can kind of go in, and then eventually we can go up to letters as well. So it's something where we have many, many, many different options, and we can kind of switch it up from one eye to the other eye, whether we want numbers or letters. But we make it really fun, kind of make it a game for these little kids just to to check to see how they're seeing. Of course, these ones are better because they're subjective. But again, we go to the other ones when we need to. Another test is the Hirschberg test. And so this is actually checking eye alignment using a little flashlight. And so you use the flashlight about a foot away from the child's eyes. And so we can see normal eyes is when they're aligned, and we can see that light reflex is right in the center of the pupils. And so from that, we know that the eyes are pointing straight ahead and equally aligned. It's on the second image here, so the straight ahead eye, the reflex is right in the center. And then we can see the reflex is actually on the outside over on this left eye over here. And so that means that the eye is actually two inwards. And so that reflex is coming out on that outer side. Similar here, we can tell that this right eye is a little bit up, the straight ahead eye, right straight centered in the pupil. And then this reflex is a little bit down, indicating the eye is a little bit up. And then sometimes children's eyes, their eyelids can actually fake us out. So they can sometimes look like the eyes are turning inwards a little bit. Kind of if you compare this bottom one here to the top one, just grossly, you can kind of, it looks like the eyes maybe are a little bit inwards. And that's all just to do with the eye shape. So that would be kind of simulating and how the eyelid looks. But we can see from our flashlight, it's nice and centered in the pupil. The eyes are nice and centered, looking straight ahead, pointing straight ahead, and equal between the two eyes. So that's a little test just to check the eye alignment of the eyes. Of course, we can also kind of do a cover, uncover test as well. Most times, again, using our hands. Don't want to put any paddles near a little baby's eyes. We can kind of just use our hands to cover one eye or the other eye to also test the eye alignment. So testing for a visual correction or refractive error or a glasses correction, we actually use retinoscopy. So again, it's an objective way to test a child's vision. In adults, we put that big phoropter in front of us, the kind of robot glasses, and we change the lenses and we ask, again, an adult, which is better, one or two? Again, children can't do that. So this is how we do it. Again, all objectively, we use the reflex from the back of their eye to kind of neutralize it. And so using our flashlight and our lenses, we can see a reflex coming from the eye. And then once we neutralize that, we can do their prescription. In children, of course, their eye muscles are very, very strong. They can focus really, really well. And so they can kind of trick us sometimes, either that they have a prescription or they can trick us when they might not have a prescription, even though we might think they do. And the way to kind of combat this is using cyclopentolate eye drops. Those are eye drops that actually fully relax the eye muscles. So the eye muscles are completely relaxed. We get the true prescription at the same time as the pupils are dilated, so nice and big. And so we have a really good reflex of the eye. So typically we do get the kids to have the cyclopentolate eye drop in the eye so that it's easier to see that light reflex and that their eye muscles are relaxed. So we get that true prescription. Another light reflex of the eyes that we use to determine, if there's a prescription or if the eyes are healthy. Again, kind of like we were talking about before, that word leukocoria, that white reflex in the pupil. So this one called the Bruckner test. Basically, we're using a flashlight again, and we're looking for if the pupil reflexes are equal or unequal. That's kind of all we look for, equal, unequal, and then kind of we can determine some further things from there. So we can see the top image here, that nice red reflex, that's equal between the two eyes, that is normal. We can see here in the other one, the V here, the second one down, the reflex is kind of a little bit up, and that is indicating that the eyes actually have a prescription in them. They are equal between the two eyes, but that's saying that eyes have a prescription that needs correcting. Same with number 2 here, the bottom one. So it's equal between the two eyes, but the reflex is bright at the bottom there. So again, another indication of a glasses prescription. And then this bottom one, again, would be what we were saying, the leukocoria. So this one on the left side here, that is the normal reflex. And on the bright reflex, that means something. And so that means either that the eye is either turned, which in this case, it looks like that eye is turned inwards. So we're having abnormal reflex from the eye that's turned inwards. And it can also indicate that eye has a glasses prescription, or like we said, it can tell us the eye either has cataract or it has retinoblastoma. So again, so something simple with our flashlight that we use to grossly examine the eyes and tell us a little bit more about the eye health. And then this one, of course, it looks like there's a lot's going on, but actually this is just a good way to examine the eyes in a child. And so, of course, we put the dilating drops in. The pupils are nice and big, and so we're using our lens here. And then our flashlight we use on our head to look into the eye. So this position, it keeps the child's legs and arms under control, and we can get a good look into the eye health. So it's not always fun. We can have kids sit there and also do it, but sometimes when they're using their arms and legs and being active little kids that they are, we do have to get a good look in their eyes still. And this is a good position to do so. We can both look at the front of the eye using our lens as kind of a magnifier, as well as the back of the eye, looking through our lens into the health of the back of the eye. So this is kind of just a little tip and trick on how to keep our active kids, under control, so we can just check their eye health there. Don't need too much of a look there. This gives us a good broad overview of the retina when the pupils are dilated. So it is a really quick examination once we get a good view. And so quickly here, just talking about the myopia epidemic, so myopia nearsightedness. That is becoming more common these days, again, associated with the more near work that we're doing, all the screens and the iPads and the phones, and the less outdoor time that we're getting. And so it's estimated that the 50% of the world's population will be myopic by 2050. And when we're nearsighted, that doesn't only mean that we need glasses to see things far away. It actually means that the eyes are longer in length. And so the eyes are growing faster, they're getting longer and getting weaker. And so that is why kind of the World Health Organization kind of has drawn this to the attention globally. There's been American Academy of Ophthalmology, Canadian journals, in Nature journal there, and even some influencers have kind of got on this. And there's a good video here on Vox talking about why more people are needing glasses now, and they again kind of go through what myopia is and the reason why we need to draw attention to this and prevent it. Now, the good news is that there are ways to actually slow the growth of the eye, whether that be preventing it, or once nearsightedness is onset, then we can actually slow the growth of the eye through evidence-based methods. And so there's 4 options here on on ways that are actually in the literature shown to slow the progression of myopia, prevent the eyes from getting worse and worse vision, and more high risk of eye health concerns. And so something as simple as glasses with a nearsighted myopia controlled design in it. Soft contact lenses for the eyes that are worn during the day. There's actually these things called orthokeratology lenses. So those are sleep shaping lenses that we wear while we're sleeping, and they can actually correct the vision when we take them out in the morning, as well as provide a myopia control effect to it. And then there's atropine eye drops, is a compounded eye drop, a pharmaceutical agent that's used once a day in the nighttime. And so out of those 4 options, the eye drop is the one that doesn't actually correct the vision. So you do need some vision correction in addition to that. But the evidence shows that it does slow the growth of the eye. Getting into it a little further, it's the eye drop has been shown to thicken that back layer of the eye called the choroid. And so if you picture like a balloon blowing up really thin versus a basketball is really more stiff. So in summary, kind of those 4 ways, glasses, soft contacts, orthokeratology lenses, and atropine are all evidence-based ways to kind of slow that growth of the eye and prevent the nearsightedness from increasing. Other things to consider, of course, outdoor time. The studies do show that 2 hours per day outdoors prevents the onset of nearsightedness. And once we're nearsighted, the correlation doesn't really work that way as evenly, but it is something important that I do tell everyone. Limiting that screen time, appropriate working distance. So of course, we don't want anything this close to our eyes. We do know that kind of having at least elbow distance away is appropriate for doing our near work. Studies out there showing nutrition, especially omega-3s, are actually protective against myopia and myopia increasing. As well as kind of there's also studies on sleep time as well, and that. And then kind of newer in the literature, more something that we need to do more studies on is red light and what red light is doing. Of course, we see red light in a lot of things, skin, dermatology areas, they're using that red light, but there may actually be a place for it in optometry. We just do have to make sure because there's kind of studies out there in China, and they actually pulled it from the market because they were using red laser, and red laser is going to damage the eye. So just things, again, needs more studies, but I thought I would mention it because that's kind of the newest thing to watch out for. These studies are changing so rapidly because they're just coming up with so many things, and it's the hot topic in optometry right now. And so finally here, just touching on Alberta Health Services. So what Alberta Health provides for coverage. And so they do have coverage towards a full eye exam for children. There is medically necessary coverage as well towards some certain medical conditions for the eye, regardless of the age. And then sometimes even special testing. So the scans, the photos, the visual fields, they may actually have some coverage towards that as well in medically necessary conditions. And so that's something where if you're going for an eye exam, just to check in with the clinic about the Alberta health coverage there in certain situations, they may be different. And so with that, I kind of ended a little bit here, 10 minutes or so available for questions. If there are any, you can ask me, and then I have provided my email there because I do know this is going to be recorded, and I'm happy to answer any questions. I can pass it back to Megan if she wants to take it from here.
Hello, everybody. Thank you, Dr. Cappellani, for that comprehensive overview. Before we wrap up, are there any questions for Dr. Cappellani? I might have the chat disabled. So, oh, perfect question and answer. Do all optometrists see pediatric patients?
Ooh, that is actually a really good question. Most optometrists should be able to. Now, of course, some people have interest in maybe different populations or whatnot, but all optometrists are trained in pediatrics, so they should be able to. But occasionally, they may recommend a colleague if it's not something that they're specifically enthusiastic about.
Thank you. If you need an urgent referral to an ophthalmologist, who does this?
Yeah, optometrists are very well trained in that. We can get to the on-call ophthalmologist right away if we need those. But family doctors also can do that, and pediatricians as well. For certain centers in big cities and large cities, I know Edmonton and Calgary, they do have the eye emergency hospitals as well as another way.
Thank you. I'll stay live for another minute or so, but if a question comes up after, or you're watching this on a recording, please feel free to email Dr. Cappellani at the email provided on this slide. In addition, you can also contact the Alberta Association of Optometrists, and we will forward your email to Dr. Cappellani. Okay, I am going to wrap it up. I want to thank you again for spending your lunch hour with us to learn about children's eye health. We really appreciate your interest and look forward to continuing to work with all of you. And as you log out, oh, thank you, thank you. As you log out, a survey will pop up. I would really appreciate it if you took a couple minutes to complete the survey to help us continue to refine our presentations. And that's all. I hope you have a wonderful rest of your day. Take care.
Thank you.